Hi everyone, and in this video, I'll be starting CVS Pharma. And in CVS Pharma, the first topic what we are starting is drugs affecting RAS pathway. What does RAS stands for? Renin, angiotensin, aldosterone system. Physiologically, this system works when the BP falls. To maintain the BP, the system is there. But certain diseases, this pathway is hyperactive. For example, in hypertension, in case of chronic CHF, this pathway is hyperactive. So the drugs which block this pathway, we'll be learning them, and particularly we'll be studying about ACE inhibitor and ARB in this video. So let us understand the pathophysiology, then come to the drugs. Now let us write here what happens when the BP falls. So whenever the BP falls, there is decrease in renal blood flow. Now when the renal blood flow decreases, there are cells, they are called JG cells. They will detect that, and there is a receptor on them, they are called beta 1. And the beta 1 releases renin. So there is release of renin release. Now this renin which is released will convert angiotensinogen into angiotensin 1. So the renin is going to convert this. Once the angiotensin 1 is formed, it is again converted into angiotensin 2. And that enzyme which convert that is called ACE. ACE stands for angiotensin converting enzyme. Now this angiotensin 2 acts on two receptor, type 2 receptor, and one more is called type 1 receptor. What does type 1 receptor do? Three important functions of type 1 receptor are these things. Now read the name angiotensin. Angio means blood vessel, tensin means constrict. So angiotensin can cause vasoconstriction. Second important thing is it can increase the adrenaline and noradrenaline. Number 3, it can also increase the activity of aldosterone. So you know what is the role of aldosterone? Aldosterone can cause sodium and water retention. So it will lead to sodium and water retention. What happens to potassium? Aldosterone decreases potassium. Now, the vasoconstriction, the adrenaline, noradrenaline, and aldosterone, all of them will lead to increase in blood pressure. So this is your physiology, how this pathway works. Now why we should learn this pathway? Because there is a condition called hypertension. In hypertension, this pathway is hyperactive. So if you want to treat hypertension, then you have to block this pathway. Second, the culprit aldosterone. This aldosterone, if it is excess, it can cause myocardial apoptosis. It can cause myocardial fibrosis. And because of that, the ventricles will change the shape. That is called ventricular remodeling. Now, what is the problem if the heart is affected like this? This will be problematic in a patient with chronic CHF. So chronic CHF patient will have aldosterone activity which is very high, and the patient will have ventricular remodeling, myocardial apoptosis, and fibrosis. Now what happens if you don't decrease the aldosterone activity? That will increase the mortality in a patient with CHF. So the heart will die, it will not pump properly. So either the patient has to receive a new heart or patient will die. So two important conditions why this pathway is important is to manage chronic CHF. Number 2 is to manage hypertension. Now you try to pause the video and find out what are the targets where I can block this pathway. So try to guess it. Number 1, what I can do is I can block the beta receptor. So these are called the beta blockers. So we can use beta blockers to block this pathway. Number 2, you can inhibit renin. So they are called renin inhibitors. Any idea what is the drug name? Yes, it is called RAAS chirin. You read the name, inhibitor of renin, chirin. and it is used for treating hypertension. So you need to know only one thing about ilascarin, that it is used to treatment of hypertension. That is the second target. So number one, beta blocker. Number two, renin inhibitors. Number three, we have another target. They are called ACE inhibitors. They are called as ACE inhibitors. Now the ACA is a non-specific enzyme and it is also required to break down two important substances, bradykinin and substance P. So this ACE is required to break down two important compound, that is bradykinin, and they are made inactive. Now when you use ACE inhibitor, what happens? The bradykinin and substance P are not broken down, and that may lead to two important problems with ACE inhibitor. One is the dry cough, and patient may develop angioedema. The patient may develop dry cough and patient may develop angioedema. So this is because of the drugs will not allow the breakdown of bradykinin and substance P. The fourth target is to block the angiotensin receptor, that is particular type 1. So these are called as ARBs. So ARBs stands for angiotensin receptor blockers, and they mainly block type 1 receptor. Anything else we can do? Yes, the fifth one is you can block the aldosterone receptor, and you know the drug name, and that is called spironolactone. The drug is called spironolactone. So we have 5 targets to block this pathway. Number 1, beta blocker. Number 2, renin inhibitor. Number 3, ACE inhibitor. Number 4, ARBs. Number 5, spironolactone. Now when the penultimately this pathway decreases aldosterone, obviously the sodium and water retention decreases, but what happens to potassium? Usually potassium decreases, but when we use these drugs, potassium increases. Remember, all the drugs what I have discussed, 5 drugs, all of them cause hyperkalemia as the adverse effect. All the drugs what we have discussed here, they can lead to hyperkalemia. For example, the beta blockers, the renin inhibitors, ACE inhibitor, ARBs, and spironolactone. They all can cause hyperkalemia. I just want to correlate one more thing. You remember beta 2 agonist, example salbutamol, causes hypokalemia. So we know that beta 2 agonist can cause hypokalemia. That's the same thing. You can correlate this. Beta blocker will cause hyperkalemia. So correlate these things. Now once we know the pathway, we understood these things. 2 important drugs we need to discuss here: ACE inhibitor and ARB. Beta blockers we already discussed, and renin inhibitor only one line. Then diuretics we have discussed, spironolactone. So let us start our journey, and the first one is the ACE inhibitors. So ACE stands for angiotensin converting enzyme inhibitors. So the name is captopril, and one more is called lisinopril. And remember, these drugs end with pril, so these are pril drugs. And other drugs are ramipril, then periandopril, then we have enalapril. So simply remember, they all end with pril. Any drug ending with pril will be ACE inhibitor. Now why I have written this and that side? Remember, these are active drugs. So in ACE inhibitor, there are only 2 active drugs, that is captopril, lisinopril. How do I remember? Remember it as Captain Lee. You know Bruce Lee, Jet Li. So like that, Captain Lee, they are also active. So remember Cap, Lee, they are active. Apart from this, all the drugs, ACE inhibitors are prodrugs. So all these are prodrugs. That means they need to be made active. For example, enalapril has to be made into enalaprilat. So Enalaprilat is the active compound. Same thing, ramipril will give rise to ramiprilat, periendapril will give rise to periendaprilat. But in practice, we have enalaprilat as a separate drug. Suppose if there is hypertensive emergency, will you give enalapril or will you give enalaprilat? Obviously, we give an active drug, that is enalaprilat. So this is about the drugs. Now moving on to the uses. Where to use these drugs? I told you they are used in hypertension. For hypertension, HTN means hypertension. These are the first line drugs. So hypertension, these are the first line drugs. Second, they are used in chronic CHF. Now, why are we using them in chronic CHF? They decrease the mortality. Now, what is the culprit for mortality is aldosterone. They decrease the activity of aldosterone. Number 3, these drugs are known to decrease microalbuminuria. So, usually the albumin should not come in the urine because albumin is big in size and it should not be filtered by the glomerulus. But if it is getting filtered, that means kidneys have started the damage. So when we start these ACE inhibitors, they are known to decrease that damage and they decrease the albumin from coming out. So they are known to decrease microalbuminuria. What is the advantage? The advantage is we can use it in a patient with hypertension plus diabetes. So we can prefer this because most of the diabetics, you know that the complication of diabetes will be nephropathy. So that means the renal damage starts and the damage is indicated by microalbuminuria. It is also preferred in a patient with hypertension with CKD. Now in CKD also it decreases microalbuminuria. Along with that, it also shown to decrease intraglomerular pressure. So it decreases intraglomerular pressure. That is the advantage. So hypertension with diabetes, hypertension with CKD, we can use it. Now it is also used in sclerodermal hypertension crisis. So which one will you use? Will you use enalapril or captopril if I give two options? So you will use captopril because it's active one. Captopril is the drug of choice. Now these are also used during MI and they are used in hypertension emergency. So what is the drug which is preferred in hypertension emergency? The name is called enalaprilat. So it is called as enalaprilat. So we understood the mechanism, we understood the uses, then we need to understand the adverse effect of the drug. So let me tell you the adverse effect of the drug like this. Let me divide it like this. The drug can produce dry cough, and another problem is angioedema. So angioedema is a rare condition, but it can be seen. So what will you do if the patient develops angioedema? The treatment is injection adrenaline. So you have to give adrenaline to correct that. So certain people will develop that. Not every patient, if you put an ACE inhibitor, develop dry cough angioedema. Certain people are susceptible for that. So they can develop dry cough and angioedema. What is the reason for dry cough and angioedema? Because no breakdown of which one? Bradykinin, and one more is substance P. What are the other adverse effects of this? Obviously, these are antihypertensives. What we see is hypotension. So they can decrease the BP. Very good. Now, when you are using it with a thiazide diuretic, when you are using ACE inhibitor with thiazide diuretic, you have to skip a thiazide diuretic dose so that you can prevent postal hypertension. So if you already there is thiazide diuretic being used, you have to skip a dose to avoid postal hypertension. Second important condition what we use, what is the adverse effect of this is the drug is teratogenic. The second important adverse effect of the drug is teratogenic. So you should not use it in pregnant. Very, very important point. Please mark it. In pregnancy, it has shown to produce renal agenesis. And I told you these drugs can increase potassium, that is hyperkalemia. And they can cause rash, urticaria, and dysgeusia. So dysgeusia means altered taste sensation. This dysgeusia is seen only with captopril. So captopril is the only drug which produces that, not other drugs. So basically remember dry cough, angioedema, hypertension. Teratogenicity is the most important question they will ask you in the exam. A pregnant lady has come to you with counseling for antihypertensive therapy. What drug will you avoid? Obviously, you will avoid ACE inhibitor. They can cause hyperkalemia, rash, urticaria, and dysgeusia. Now, if the patient on ACE inhibitor develops dry cough, what is the next step? If they ask in the exam, what will you write? The next step is to change the patient to ARB. Don't give cough syrup, don't do chest X-ray, don't do MRI and all. Just give the cough syrup. No, you should change the patient to ARBs. Now, once we understand the uses, adverse effect, let us understand the contraindications where we should not use. Now, if the patient already has hyperkalemia, we should not use it. So both patient is already having hyperkalemia, if you use ACE inhibitor, it will worsen up. Second, if the patient has bilateral renal artery stenosis. If the patient already has bilateral renal artery stenosis, if you give the drug, patient may end up with renal failure. Number 3, we should not use it in pregnancy. Why pregnancy? Because it is teratogenic drug, we know it, and you should not use it in a patient with history of angioedema. So if he has a history of angioedema, try to avoid this drug because it causes angioedema and it's a life-threatening condition. Or if the serum creatine is too high, that is more than 3 mg per deciliter, you have to stop it. Once it comes below that, you can start it. If it is too high, we should not use ACE inhibitors. This is the contraindication. Remember, particularly pregnancy. Then once we understand a contraindication, what about drug interactions? What drug? You decide and tell me, can I use ACE inhibitor plus spironolactone together? Take a guess. Can we use them together? What is the problem? If I use them together, the problem is hyperkalemia because both the drug, they can cause hyperkalemia. The second one is, can I combine NSAID and ACE inhibitor together for a very long period? Long term use. Can we do that? Now, why this situation arises? Because most of the patients are hypertensive and they will have osteoarthritis. They start taking this analgesic as well as ACE inhibitor. What is the problem here? Let me explain that. Now, this is the nephron, and we have the afferent arteriole, and this is the efferent arteriole. So normally what happens is, in the afferent arteriole, we have prostaglandins, which causes vasodilation. And here we have angiotensin 2, which causes vasoconstriction. Now what happens when the blood flows? Because here it is vasodilated, the blood will go easily. And here it is vasoconstricted. There is filtration of the blood and you see GFR. So when you see GFR, there is urine output. That means kidney is working correctly. So this is the normal. Now what happens when I use this very long period? Now NSAIDs are going to inhibit prostaglandins. ACE inhibitors are going to inhibit the action of angiotensin 2. Now what happens here is, this will become ulta. So here the afferent arteriole becomes constricted, efferent arteriole becomes dilated. So what happens if it is constricted? whatever the blood coming will be less, and whatever blood is coming, I'll explain here, whatever blood coming is less, and that will get diverted towards efferent arteriole because it is dilated. So when you use it very long period, so it will decrease the GFR, and in the long run it can lead to renal failure. So the long term use of this is absolutely contraindicated. The same phenomenon work out if I explain bilateral renal artery stenosis, why ACE inhibitors are contraindicated. So if there is bilateral renal artery stenosis, the problem is the afferent arteriole is receiving lesser blood because the artery supplying the kidneys are stenosed, so very less blood is coming. So this is the afferent arteriole, and this is the efferent arteriole, and this is the glomerulus. Okay. Now in bilateral renal artery stenosis, the amount of blood flowing is lesser and very less filtration is occurring. Fine. But when you use ACE inhibitor, what they do, they block the angiotensin II action, and that will dilate it further. So the efferent arteriole, that is the efferent arteriole dilates, whatever small amount of blood is coming is diverted, whatever small amount of blood is coming is diverted towards the efferent arteriole. So what happens, there is decrease in GFR, and that will lead to renal failure. So that is the reason why it is contraindicated in bilateral renal artery stenosis. So I'll explain again. The point is, in renal artery stenosis, the blood flowing to the afferent arteriole is lesser, and if I use ACE inhibitor, it will dilate the efferent arteriole. Whatever lesser amount is coming, it is not filtered, it is diverted towards efferent arteriole, the GFR decreases, and patient will have renal failure. So sometimes acute renal failures have occurred with that. So that is about drug interaction, contraindication, uses, and adverse effect of ACE inhibitor. Now when we had ACE inhibitor, then what is the reason why we came with ARBs? The reason is the dry cough, angioedema risk. So the next group of drugs are angiotensin receptor blockers. Can you tell me which type 1 or type 2? Yes, obviously it is type 1, and in short we call them as ARBs. So what are the drugs you need to keep in your mind here is candesartan. So sartan, they end with sartan. Candesartan is also used for one more condition. It is used in migraine prophylaxis. So when we discuss migraine, I'll tell you again candesartan there. Then we have irbesartan. Then we have losartan. Now losartan, remember, it lowers two things. What is that? It decreases uric acid. Why it decreases uric acid? Because it has uricosuric action. The name is losartan, and also it is shown to lower thromboxane A2, which is an advantage. You know, thromboxane A2 causes platelet aggregation. If you decrease that, it's an advantage. Platelet aggregation decreases. So we have basically candesartan, irbesartan, losartan, and valsartan, then olmesartan, then azilsartan. So if you read, all their name end with sartan. But one important sartan I just want to tell you is telmisartan. Very, very important. Now telmisartan is important because it is longer acting ARB. So among all the ARBs, the longest acting is telmisartan. And one more advantage is it has PPR gamma agonism. So it has PPR gamma agonistic activity. If you remember a drug which is a PPR gamma agonist, do you remember in diabetes we have a drug called pioglitazone? So pioglitazone also has PPR gamma agonist. So because of this, pioglitazone is used in diabetes. Suppose a patient has hypertension with diabetes. If the ARB should be chosen, telmisartan will be the best choice because It has PPR gamma agonism, which will help in diabetes treatment also. So that is telmisartan for you. Once I know ARB, what are the uses? So very easy to conclude this. Uses are same as ACE inhibitors, so nothing changes. What are the adverse effect? It is also same as ACE inhibitor, but there are two important exceptions. Except the dry cough and angioedema, they are not seen. So drug interaction is also same as ACE inhibitor, and contraindication also same as ACE inhibitor. But what there is an exception, even if the patient has history of angioedema, we can use it. So it's same, everything is same except that two problem, that is dry cough, angioedema. Contraindications are same, drug interactions are same. So both they're like same thing only, except they don't produce dry cough and angioedema. So that is about drugs affecting RAS pathway. Remember, ACE inhibitor end with pril, ARBs end with sartan. Both are same. The only difference is bradykinin substance B breakdown. That breakdown is inhibited by ACE inhibitor. That's why they will have dry cough. If the patient has a dry cough, shift the patient to ARB. That's it. Angioedema history, don't give ACE inhibitor. And if the patient suddenly develops angioedema, you can give adrenal injection. And pregnancy, don't give AC or ARB. Both are contraindicated. The other drugs which block is this pathway are beta blockers, renin inhibitor, alaskarin, and diuretic spironolactone. So that is about drugs affecting RAS pathway. Thank you all.